Respected Chair, thank you for a very kind introduction, dear colleagues. First, I would like to express my thanks to the organizing committee and Dr. Banshi for this kind invitation. It's a real pleasure to be here today as a part of Diabetes Education Study Group and to share with you this topic of measuring outcomes of DSMES. So, if you're speaking about the therapeutic patient education as a field of research, it was almost unknown until 1990s. There was just a few articles on that point, and since then, this interest in this therapeutic patient education in general, not just for diabetes but for many other chronic diseases, starting to raise this interest. And as we can see now, there is a lot of articles on this subject, but main of these articles are coming from USA and a couple of other countries like England, Australia, Canada, China, and so it is relatively developing interest for researcher, the therapeutic patient education, which is showing how important it could be in the treatment of many chronic diseases. So it is the same with diabetes. So if we are talking about the measuring the outcomes of or evaluate TP or DSMS, it is almost the same. The second is just for diabetes. This process is actually gathering of relevant, reliable, and valid information. Then we should analyze the data and finally compare it to the established standard for treatment education. And of course, to evaluate TPE is based on criteria and indicators, and always it looks to many various aspects of the disease, including some biological, clinical, educational, psychological, and many other factors. So at the beginning of the SMEs, it was they thought that it was evaluate diabetes knowledge and skills that patient can get or gain after the process of education, as well motivation. But very soon it was considered that this is not enough, and with this, patient can get knowledge and skills, but this cannot significantly improve the outcome of their diabetes. So finally, it was concluded that as an educators, we should aim to change the patient behavior, because this is the thing that if the education is able to change the patient behavior on a long term, then can impact the outcome of many chronic diseases, including diabetes. So only the interventions that can change patient behavior can improve the outcome of the disease. So from the ADA, these are the actually explanation how we are, what outcomes do we should we measure after the process of therapeutic patient education. And in general, the outcomes are classified into two categories. The first are the process data, which are measuring the quality of the process of education itself. And the second are the outcomes data that can be different, related to clinical, behavioral aspects, then patient-reported outcome, and finally patient-generated health data, which are data from their home blood monitoring, CGM, blood pressure, and many other parameters that patient can measure by themselves, and then we have the insight into this measurement. So I will say a couple of words for each of these outcomes. First, regarding the clinical outcome of this DSMS. So it is the main important, of course, is reduction of HbA1c or improving the metabolic control. And it is very well known until now that TPE or DSMS is able to improve HbA1c in patients with diabetes. There's a different percentages that are reported over time, but which are going up to even 1% improvement, which finally can improve not just metabolic control, but it will delay the appearance of chronic complications and, of course, reduction of all-cause mortality in patients with diabetes. And what is even more important, it is very important to introduce diabetes education at the very beginning of the disease, because if the patients are able to achieve the good metabolic control at the beginning of the disease, it will improve the final outcome of diabetes, and this is so-called metabolic memory or legacy effect. And there is a lot of proofs that the legacy effect do not exist just in clinical trials, but also in the real life. So we can see from this trial that diabetes control and early education during the first year of the course of diabetes is associated with a lower future risk for diabetes complication. And if at the beginning of diabetes HbA1c is above 7%, in those people we will see the 20% higher risk for future mortality. And if the HbA1c if above 8, this risk will be about 30% for more frequent microvascular events and also increase of all-cause mortality. So DSMS and at the early beginning of the course of diabetes is associated with a lot of benefits, including lower A1C, better glycemic control, better maintenance of this control during patient life with diabetes, better long-term outcomes, lower risk of complete complications, and of course, very important, lower economic burden for countries where these patients are living. And we already know that they live more in the countries that are poor or lower or middle income countries. So also, I'm showing this meta-analysis which analyzed 36 studies and more than 20,000 patients, and we can see that early intervention with therapeutic patient education, especially from nurses and pharmacists, is associated with a great improvement in metabolic control, and of course this can be beneficial for the patient for postponing the complications of the disease. Regarding the behavioral outcomes, it is also very well known until now that TP improves the quality of life, and not just that, but also promote the very healthy lifestyle behavior, better diet and physical activity. And also it shows improvement in self-efficacy, which is very important because patients have to be alone with their diabetes and take care of any component of diabetes. And this DSMS empower patients to take control over their diabetes, to increase healthy coping, and of course to decrease diabetes-related distress. And as previous speaker said, this measure, it is proven that it's better than metformin, and still it's not so awfully prescribed as metformin. And finally, patient-reported outcomes for people with diabetes. This is actually prompts, these are questionnaires that we are using to measure patient-related outcome, especially health-related quality of life. So there are many different prompts in research and in clinical practice, and which we will use. This is the main question. And if I can help, the most used questionnaire, the SF12 and 36, both of these questionnaires are validated, quite reliable in different languages, but still with questionnaire will you use, and maybe combination of couple of questionnaire, it will depends on interest of your research, and of course the aim of the study, or aim of your interest that you have in your research. So the prompts are very important because they can give us a lot of information about patient health status, but also of the quality of diabetes care, which we cannot find out in some other clinical quality indicators. And also it can help healthcare providers, to have an insight into the patient's need, what they really need to improve in their treatment of their diabetes. And of course, they can improve the relation between healthcare provider and the patient. And of course, finally, it can improve the quality of life of our patients with diabetes. And it is also very much important to include this into early beginning of the course of diabetes in our patients, because it is very important from the beginning for patients to have a good adherence to the treatment and to all measures that they can undertake to cope with diabetes. It is very important at the beginning for them to perceive that diabetes control is essential for their future prognosis and the future development of complications. It can really decrease the diabetes-related distress and to increase quality of life. And it is shown that if at the beginning of the diabetes there is a poor reaction to diagnosis, this will predict the future. In the future, that this patient will have the lower quality of life and the most frequent complications. So these are the known benefits of the SMS, which are proven until now. It improves the glycemic control, quality of life, patient follow-up, higher patient satisfaction, and finally, it decreases the risk of complication and healthcare costs. But still, the utilization of diabetes education is absolutely low. Depends who is publishing. This percentage is going from 1 up to 50%, but not more than 50% of all people with diabetes, because it is still not recognized, not just from healthcare providers, but also from the systems as a very vital part of diabetes treatment. Also, if we have to believe that diabetes education is a key for a brighter tomorrow for our patients, because it can improve many aspects of the diabetes. But there is just in a very small amount, people with diabetes are receiving diabetes education in the early course of their diabetes, and that's why the outcomes of diabetes in the whole world is still under our expectation, despite the all new treatments that we have and technology. And even if you're seeing our guidelines, so many proposals for so many new drugs, combination and etc. And if you can see in the upper part of the slide, it is mentioned that DSMS should be the beginning of the treatment of diabetes. But I think so that DSMS should be in the center of the treatment at the very beginning of the course of diabetes, and then it will the better utilization of all other treatments, including technology, because the patients must be trained to adapt all this technology and drugs that we are offering during our treatment. So if I can conclude, DSMS should be a key component of diabetes management. Still, it is not. Then this intervention are adaptable to many various contexts, and it can be delivered in a many different way. It is very important because now we have a really strong evidence that it can improve the outcome of diabetes. But the most important, of course, stays that it is important to provide all people with diabetes with DSMS in the very early beginning of their diabetes for better outcome of their disease. So thank you for your attention.